Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator. This is session number 30 and number 16 since our partnership with theheart.org. We have another interesting and genuinely complex coronary intervention case for you today. I would also like to welcome the numerous interventional cardiology fellows who have a part of the curriculum in Beijing, China, as well as the VA hospital in San Juan, Puerto Rico. Beijing, from what I can see, is 9 in the evening, a little beyond your dinner time, but hopefully you'll find this a very useful academic case. Without any further delay, let me take you to the cardiac cath lab where Dr. Kinney and Dr. Sharma are about ready with today's case. Samin, good morning. First of all, congratulations to Anu. I believe she's had a promotion and she's the new director of the cardiac cath lab.
Yes, of course. That was long due. She has been working as a full, in that capacity, being associate director, and now well-deserved title. So she received this announcement was made last week, and I really, thankful to her that her controlling the cath lab and managing cath lab, I was able to do all my outreach and networking. And that networking is the way of the future. As you're saying that Beijing and Puerto Rico and so, that no longer it's there is no boundaries for anything, whether it's a patient or it's a teaching. And that is what we have established in both, whether clinical or by the webcast all over the world.
Congratulations. I know it has been so many years of hard work, and I meet with your fellows all over the world and they express their profound gratitude to what you have taught them.
Perfect. Now we actually have very interesting case and we are ready to start. If I can just introduce our team, and as you see that time to time we get another guest. The interventionalist actually is not guest, is a part of our team, Roxana Mehran, and with the fellows here, knowing that one of the topics I'll be talking today is the contrast-induced nephropathy, and of course she being a master, and with the Mehran classification of the risk factor of the CIN, I felt that it is very imperative that we take her opinion in many of the statements which are not clear-cut, and I will be making during this our morning webcast presentation.
Good morning, with that, Roxana, and welcome.
Good morning, Shamir. It's wonderful to be here as part of this, and I personally want to congratulate both Dr. Sharma and Dr. Kinney for their incredible promotion, and they've been leaders in the field. And as you know, Dr. Sharma is my first teacher in interventional cardiology. He trained me in angioplasty, so I have a deep devotion to both of these folks, so it's wonderful to be here.
Okay, now let's get to our, because this is a case which will require a lot of technical help and work while we present the case, and if we go to the slide, this is our case number 16 with the patient presented on October 21st with progressive dyspnea and chest pain at rest and shortness of breath, ruled out for MI, was other hospital transferred here, and cath revealed 3-vessel disease and normal EF. Patient had a stent in the mid-LAD in the past, but on the transfer found to have significant new lesion in the distal LAD which underwent Promus DES and did good. Patient actually, these are the risk factors, also CVA, which complicates with the AFib that need to be on dual antiplatelet therapy, and also patient has chronic renal insufficiency with creatinine clearance of 38. So it makes that the chronic kidney disease stage 4. So clearly that is one of the big issues nowadays with elderly patients with their impaired renal function, that what we do and what the guidelines tells us to do. Is there any particular way to prevent and manage these patients? Now one issue comes that once you need dual antiplatelet therapy after DES and patient needs long-term anticoagulation, be it the warfarin or Pradaxa, the question comes what you do with the dual antiplatelet therapy. We actually have published that combination of dual antiplatelet with ADP receptor being given every other day seems to have a good efficacy and less bleeding, because we know you can give all 3 agents, that will create a problem. Now, as far as the CAD is concerned, which is just going to show, the question today will be the right coronary artery, which has multiple calcific lesion and syntax score 29. So if we put into our appropriateness risk, which clearly has become to the highlight, although this patient did not have any functional study, but based on the 3 vessel disease and symptoms will appropriate the green bar. Now, Anu, you can take us through the angiogram now.
Yeah, so if you see the left side, left main is non-obstructive, and what she had was a stent done in an outside hospital. So
Anu,
then she came back with the...
No, angiogram has not come yet.
We just need you to pause one moment. Yes,
Yeah,
we have
sure.
it now. Go ahead.
Okay,
please.
so if you see there, you have a non-obstructive left main and prox LAD, again mild disease. So when she presented to us, she actually already had an intervention of the LAD before, but she had new lesion in the distal LAD, which is where we did a stent. Now in the circ, there is a high lateral which is moderate size, but there is a 60-70% lesion in the prox circ, but a small size OM which is totally occluded. And this is the cranial shot with LAD. After the 2 diagonals, the stent that was done here looks okay. This is our LV function, near normal, and this is our RCA. If you see, calcified osteal disease and a lot of damping, her blood pressure usually runs at 140 or so. As soon as we engage, the pressure goes down to less than 100. The prox RCA itself is non-obstructive, but as you see, the distal, there's actually a stent. Stent is okay, but further down there is another 60-70% disease, and more important is after the PDA, if you see the AV continuation RPL, again calcified and multiple lesions in the AV continuation RPL area.
Therefore, challenge-wise, with the technical, that how are you going to manage this? That one of the biggest issue comes that what guide engagement in this osteal lesion. I think that's one of the very important issue, knowing that you can use some aggressive guides for the distal lesion, because she has very complicated distal and AV continuation lesion. We need to do all in order to supply downstream.
So whenever there's osteal disease, the common teaching is try not to use an aggressive guide. Just with the engagement, we may cause dissection of the vessels. We have seen spiral dissection of the RCA using the Amplat guides. So in this situation, since we have to take care of the distal vessel, I think we can go to a guide which is in between. The FR probably will not give us any support. If it is just we were going to do the osteal, maybe just an FR guide would have been good enough. But here, since we need some support distally, better to go with the Lima guide. The other guide, the suggestions still are that you could still go with an Amplat's guide, but you have to be very careful when you're doing the osteal lesion. So best I think we have selected Lima guide.
Now
Then,
in some situation, you could do that if you think that the distal delivery is a problem, then you can treat just the ostium, put the stent, and then so that makes it easier to use some more aggressive guides, no?
Anu, Lima guide with side holes 7 French or 6 French?
we have a 7 French guide here. Since there is calcium and we are planning to do rotational atherectomy, and if we have to go up with the burr size, that's the only reason we've gone with the 7 French. If it was a non-calcific vessel, we could have done with the 6 French guide. And then, of course, taking care of the ostium would be okay, but the delivery of the stent in the distal RCA and in the AV continuation RPL could be, that's where we probably are going to have a challenge, whether we are going to use the double wire technique, or we may be needing some newer device help in this situation once you have done the rotational atherectomy.
And particularly what is you have been using, and we have shown that demonstration.
We see the guide liner that we have been using often in this situation, that once you have done the debulking with a single wire, you can use the guide liner. Usually that helps, it's like an extension of the guide, that you extend it all the way almost from to the mid RCA, then you'll be able to deliver the stent through that very easily.
Very good. Now what we'll do, now tell us what you start, because then I'll take my 10 minutes for a slide presentation, so that you tell how you are going to do, and we go off to our presentation.
Now, since it is a osteal right and a complex right, we do with in an elderly patient, as you see here, we do have a temporary wire because we are going to do rotational atherectomy, a 7 French guide and a long sheath, so that we'll get a good support. With the Lima guide we'll engage, and then since we have to, plan is to take care all the way the distal lesion, AV continuation, RPL, we are going to use a over the wire system. So we have a fine cross fielder, so we are going to cross, then exchange it to the rotawire, and distal vessel we are talking about 275, between 25 to 275. So the distal rotational atherectomy will be done with 1.5 burr. Also what will be challenging here is the rota burr is not going to reach to the distal RCA. So once we do the rotational atherectomy of the ostial RCA, we will have to use Dynaglide to get the burr down to the distal RCA and AV continuation.
What if you just go with the 1.75 burr? I think you could get it. Yeah, I think we should try 1.75. Maybe it will be one single burr. Could be. Because I don't know whether AV continuation you need a rota. See, there's not that calcium. Calcium is in the ostium and the distal RCA. So that many times that it doesn't have to be a clear cut that you need to do all the cases with a rotational atherectomy. You do only lesions which are calcific, and others you can just do a PTCA. But clearly the wire movement, anytime when you are advancing the wire and crossing the lesion, will give you an idea that how calcific and stiff that lesion is.
Well, that will first of all make the case far more simpler than trying to do the distal lesion, which I think will be a challenge with both the 1.5 or the 1.75. Anu, excellent strategy, excellent technical tips to watch out for the things which could go wrong. Sameen, what do you have with your academic teaching points for the case for people to understand?
I'm sorry, what? Yes. Yeah. We'll start with those 2 points as we always try to pick pertaining to the case, and those being that new stent design, the third generation, actually no longer we are in second, we are the third generation era, and the choice of contrast media to reduce acute kidney injury, or we used to call contrast-induced nephropathy. So the basically third generation, what is happening is that just to give overall view that we are going to the thinner struts. You continue. Yeah, thinner struts and the thinner struts and basically the polymer, which is either bioabsorbable or very thin polymer. That's where we are now. Whether it will be a bioabsorbable stent is a different story, but those are the two important development, and these are the 3 new stents which are available or soon will be available. Zions Prime was the first one to come with the Abbott, then Resolute of Medtronic is with the FDA. Hopefully we'll hear it very soon, which is on addition to our already Endeavor, and then the Promus Element with the Boston Scientific, which is the platinum chromium, and the same everolimus drug. And basically these are the various stent patterns. The key remains is that as stent thickness has really gone down to a very small 0.0032 inch, and the drug which seems to be most effective, everolimus, has been used, and the polymer thickness actually has decreased. Now these basically some slides just to show that the thin stent strut coverage is the way to go at present, and this platinum chromium has shown to provide radial strength. Remember, cobalt chromium has been criticized to issues in terms of the radial strength, that it's a recoil and you cannot extend the calcific lesion. Clearly it's more radio-opaque as well as flexible, and at the same time providing radial strength. And I would say there is some basis to it besides the bench testing, that how can we say this radial strength issue. The second issue, as I mentioned, with the recoil shown in this slide comparatively, and conformability, very important, because that how the stent conforms to the vessel the diameter, the basically your angle that you put into the RCA, it takes the shape of the RCA, and clearly the lower the number, better it is. And you can see the Promus Element really on the far right side in terms of this conformability indexes. Now then is the fracture resistant. You know, stents always have an issue in terms of the fracture resistance, and the fractures, particularly thin stents, have been shown in elastic. The stent situation has been an issue, so that the platinum chromium comes with this additional advantage. Now then, this is a very important sub-study which was done in the platinum, and that basically is that about, we know when you put a stent, about 6% of them you have incomplete stent apposition, we call ISA. Now what happens at follow-up? It has been shown that some of them disappear, some of them develop more acquired late apposition, and of course that is higher with the patients with have acute coronary syndrome. And very interesting, with the platinum QCA and IVUS study showed that what you left at time 0, incomplete stent apposition, at follow-up disappears. Now you say, how can that happen? I think this really speaks for the radial strength, and the stent continues to expand so that at follow-up you do not have a stent apposition, and of course we need few more studies to answer that. Then biggest question comes, where exactly is the stent in terms of the marker? And this is actually a very illustrative slide which shows where the Zions prime, where the Promus element and so, and looks like that Zions prime and so your stent is at the middle of the marker. Wherever that 1 millimeter marker, most of the stents are at the middle of the marker, but Promus is inside the marker. And of course the issue remains is the distal overhang, which is much smaller with the Promus, and also has been shown that it is a more non-compliant balloon. So same thing like a cipher we used to deploy 16-18 atmosphere is a routine, will become routine practice in my opinion with the platinum chromium stent. And we know we already have we used actually ion with the paclitaxel of the platinum chromium, and of course the Promus element is the one which we'll be using today, and some data I will show. And lastly, this will be available as a BMS also by name of Omega stent, and there is a new stent will be available in this abluminal coating. Now platinum, many trials, most important being our workhorse randomized clinical trial, which was non-inferiority to existing cobalt chromium everlumus eluting stent, and basically came numerically about 0.5% event was higher, but this was within the non-inferiority, and therefore identical primary endpoint met in the platinum trial. Maybe I can ask Roxana on this issue, that we talk a lot of the non-inferiority, that as an interventionalist, what do we understand from the statistical point when we're talking non-inferiority, although stent was 0.5% inferior compared to cobalt chromium?
Statistically speaking, when you look at this, and as long as you are within the bounds of the upper bounds of the non-inferiority margin, you can claim non-inferiority. That's the way you plan the study. So the fact that it's a little bit, looks like it's a little bit performing a little bit less than the control stent doesn't really mean anything statistically, as long as you meet it within the non-inferiority bound. And I know that a lot of people would look at that and say, but I think if you, the way it is statistically, that if you actually had twice as many patients, that you'd most likely move towards equivalence or go backwards towards, so that you would no longer show that. And that's really kind of the way you have to think about this when you're looking at statistical bounds.
Okay, now, Anu, you want to show anything about the guide? Okay. Then basically the 1 year outcome, as you can see, identical. That's ditto. You know, all these patients, about 1,500 patients, whether you take a major endpoint of the death MI, TVR, stent thrombosis, absolutely on top. The few percent point which came out difference was just basically related to our target lesion revascularization, but 0.5%. Now, the issue has been with the polymer, as I mentioned, that more and more we are going away with the polymer because of the degradation, polymer coating, and so forth, so that science and field is going away from this DS free polymer. And in this, with the platinum chromium, is the synergy stent, which will have only abluminal bioabsorbable polymer, which is basically showing towards the lumen, and basically away from the lumen. So that's where your intimal hyperplasia occurs because of the injury, and hopefully that will require less duration or shorter duration of antiplatelet therapy in these patients. But abluminal bioabsorbable polymer has been studied by some compound and some trials, but they still need to be, concept still need to be proven that will it be effective. But clearly, as I mentioned, the polymer is taking a lower and lower, and of course now the bioabsorbable stents. Now then, question, what is the other comparison? We knew that Endeavor versus Resolute DES 1 year data, again, were identical with the Zions V, except the stent thrombosis was definite stent thrombosis was higher with the Resolute versus with the Zions 1.2 versus 0.3. And then they presented a 24 months data in Lancet 2 months ago, showing that again, identical performance of two stents. Yes, there was a trend towards higher. The stent thrombosis is definite and probable with the resolute compared to Xion. So that basically, if you compare second generation stent versus third generation stent, it basically comes out to be the same level overall at present, because this still will, I'll call it a second generation. And only for the third generation stent, the data was from the platinum, as I showed you. Then the second issue comes with the choice of the contrast media to reduce acute kidney injury, and these are the contrast media classification based on their osmolarity, ionicity, and of course the various monomer or dimers and compounds which have been shown, including their viscosity. Basically what we have seen is that we have gone away from the ionic to the non-ionic, and from hyperosmolar to the low osmolar contrast, or whether it should be isoosmolar, which is our blood viscosity of 200 milliosmol. Now, why it is issue? Because acute kidney injury caused by the contrast is harmful, which have been shown short and long term, and we know it takes 2 to 3 days, so that you need to follow these patients a little longer. Now, various mechanisms for contrast nephropathy, I think the most important in my opinion is the decrease of the blood flow and redistribution of the blood flow from medulla to cortex, and of course the direct injury of the contrast material and the free radical scavenger is the reason. Now, of the various factors, the non-modifiable, modifiable, I put it in this slide, and important being from which is our concern today is the contrast, ionic versus high osmolar. Those are associated with higher contrast induced nephropathy. Now then, what about the non-ionic and low osmolar? There are many trials have done to answer that question, which is hyoaxal non-ionic versus ionic agent, and seems to be that non-ionic in the early studies shown lower as long as the low osmolar contrast. So basically, field has moved completely, particularly the patient. I would not even say in the CIN patient. I think interventional cardiology, nobody uses high osmolar contrast at one point. There is issue with the cost, but there is no longer the cost issue because all these agents have become quite cheaper. Then question is there a difference into individual low osmolar or isoosmolar contrast? And of course, some studies with the iodixinol and iopamidol, as you can see on the right side, clearly again no difference in contrast nephropathy. Then Roxana did this trial of the ICON, compare ioxalate with iodixinol, again no difference in the overall incidence. And then there were two studies, and that really with this field opened up based on the iodixinol and iohexol, isoosmolar and low osmolar in the nephric study showing lower CIN based on the iodixinol group compared to iohexol. Iohexol is our omnipeg, and that really opened the field that probably iodixinol is a better agent, particularly patient with a diabetic patients and so. And we actually published our meta-analysis of the published randomized trials, and we found no difference in iodixinol and iopamidol. So that clearly the field was open in order to really prove that hypothesis, that what was seen in the nephric trial, that was it true. And that led to the major randomized trial of the CARE, one of the largest randomized trial of the patients with the renal insufficiency of the 480 patients. And this was published 3 years ago, that comparing iopamidol and iodixinol, you can see numerically that in all categories, no matter what you have the definition of contrast-induced nephropathy or AKI, that it's lower in iopamidol versus iodixinol group. Once you go to the individual subgroups of the diabetics, N-acetylcysteine and so, that clearly that you start seeing some trend, not again clear-cut, but trend towards a lower incidence of contrast nephropathy with the iopamidol compared to iodixinol. So basically, that concept which was seen by nephric, you can see that the diabetic patients were in the trial, in the CARE, were more than what were in the nephric trial, and we did not see that even a signal of what was seen in the nephric study. Now, maybe Roxana, you can comment on this point at this time.
You know, given the CARE trial being the largest trial comparing contrast media, I think there's a clear feeling amongst everyone, given the data, that amongst the low osmolar compounds, certainly iodixinol is not superior. And that was all driven by a single trial, the nephric trial, and actually, you know, the iodixinol made it on some of the guidelines and the previous guidelines. And I think the new PCI guidelines, which I know you're going to discuss, really do not give a choice of a contrast media. And I think the more important things for us is not to focus so much that the isoosmolar compound is going to reduce contrast-induced nephropathy or contrast-induced acute kidney injury, rather, but to really think about the risk factors of the patients and some of the things surrounding the procedure to try to decrease the volume, and I know you're going to talk about that. So this trial really was the largest trial looking at the contrast media and really kind of putting to bed the superiority of, let's say, an isoosmolar compound. I think importantly, iodixinol, while it has a lowest osmolality, and you would think if osmolality matters, it has the highest viscosity. So there are some prices to be paid back, and at the moment, you really can't say that one is better than the other.
Perfect. Now then, the most important issue was that is it the CIN or is it the contrast? And this is actually, we had the 1-year follow-up of the CARE trial. We brought those patients back and defined major adverse event of the death, stroke, MI, and end-stage renal disease requiring dialysis, and remaining being the other events. And basically, what did we find? That patients, actually also, we did a cysteine measurement, which seems to be a better marker of acute kidney injury compared to others. Wait, 2 minutes will be done. Of the kidney injury, and basically confirm the finding that yes, once you have an increase in creatinine or cysteine, there is a higher incidence of major adverse event at 1 year. Now, more important for us was that is there a drug interaction? And you can see here, compared to iopamidol and iodixinol, that in patients with the iodixinol had a higher odd ratio of developing major event at 1 year, and actually it's a 3 times higher if you compare. Taken all the patients together, that in the CARE trial at 1 year follow-up, 3 times higher major adverse event with the iodixinol compared to iopamidol. Then the last issue was that is the patient, the outcome are based on the contrast nephropathy, these patients who have high serum creatinine. And this is a very, very interesting slide. That basically means if you take a patient with iopamidol with a CIN as a reference, if you did not develop CIN, your major adverse event is low. Now, if you develop CIN with the iodixinol, your hazard ratio becomes almost 2.9, means 3 times. And if you did not develop CIN, remains 1. So basically, it speaks for that clearly it's the CIN which really all the risk factors together, if you come basically control for it, that's the CIN, and particularly in the trial, we're using iodixinol was associated with adverse long-term outcome. And of course, this has been shown by many other studies and so. Therefore, this goes back to the guidelines very simply, quickly. The back in, as Dr. Mehran pointed out, that back in 2006, 2005, and 7, isoosmolar contrast agent was preferred. But clearly, since that data, CARE was such a major randomized trial, the guidelines were changed, that no longer they put into the low osmolar contrast media other than ioxalate or iohexal, because clearly the Omnipeg iohexal was associated with higher contrast-induced nephropathy, so that was removed. That was only labeled as a bad agent, but everything else. Now then it led to a subsequent, because more data came and the field kind of became very muddy, that there was no one superior agent. So that basically in the latest guidelines of the acute coronary syndrome earlier this year and the recent PCI guidelines actually do not make a point of any contrast material. They do emphasize that you need to risk stratify these patients, and most important is hydration, hydration, hydration. And patient with kidney renal dysfunction, you decrease the contrast volume. And then basically this is where it is that since the field is not very clear, it is tough to make any recommendation. Although I can tell you based on the CARE trial and some data, you could make it a point, but clearly for the committee, it was not clear that they can come up with a one single agent as a preferred agent. Yeah. Roxana, you want to make a comment on that?
So my last, I think that this whole field of acute kidney injury is really opening up a lot of doors for us to really understand what's the real outcome. Is it really the acute kidney injury, or is it about the patient who's at so much higher risk for developing this acute kidney injury? And what can we do to actually reduce these complications? Certainly, we just heard from Dr. Sharma that the type of contrast media, you really, obviously, low osmolar, but amongst the low osmolar compounds, certainly between iodixonol or iohexol, you can't really make a specific choice, although the CARE trial really shows you actually the other way around. But certainly, the more important piece is in assessment of the patient's risk. And I think these biomarkers like cystatin C, as you discussed with the CARE study, and GAL, are going to really, really come into play in finding that high-risk patient individual. There are many, many clinical trials ongoing, and we're going to lead a clinical trial called Renal Guard. It really does have a lot to do with the hydration status of the patient, using the concept of keeping the kidney well hydrated and really keeping that urine output going. And we're going to look at that in a one-to-one randomized fashion using the Renal Guard system with a systematic hydration and diuresis of the patient. We're really doing everything we can to reduce this important complication. Finally, I think in order to really put this to bed, it's important for us to do a very, very large study where we reduce contrast-induced acute kidney injury, but really show that by reducing that, we've actually reduced mortality and permanent renal damage. And that's a clinical trial that we're designing and hoping to do, and we're thinking that this really should be one of the important focuses of the future.
Perfect. Now, Anu, we are back to you now.
Yeah, Roxana, excellent review. Samin, in the meantime, as I'm sure you're going to start showing where Anu has reached, there is an important question which has come from, this is a question from Dr. Anshul Jain from Sri Action Balaji Hospital. It's a hospital in New Delhi. They do great work. His question is there any merit in using extra support rotawire for these cases where support is going to be an issue?
Okay, Anshul, how are you? He was trained by us, Anshul Jain. So I think if you can see here, I did say the guide selection wise we go to Lima guide, but if you can show the angiograms there, see how the takeoff of the RCA is anterior and almost shepherd crook, not complete shepherd crook takeoff. So the Lima hook was longer than what we expected, was not the best guide at all in this situation. You can actually use what is called as a no torque guide in this case. But what I did was took the 7 French FR guide. See the way you place it. You place it in the ostium, and then take you have your fine cross and any kind of your workhorse wire of, ideally if you can have a glide wire that is available. This is a fielder that you are able to engage, means wire the vessel with your guide sitting in the ostium so it exactly floats, and then you wire the entire vessel, then get your fine cross. So now you know, you then negotiate your change your rotation, rotate your guide catheter so that you can now get to the ostium and engage the RCA, then exchange it to the rotawire.
Good. Okay, now we are ready.
Yeah.
Okay, now that has been done. Now question comes is that extra support versus, yes, this is a kind of case, the extra support will help you in doing a rotational atherectomy. Go. Yeah, now this is a 1.75 burr and wire is distally. Yeah.
Wire is distal and is the same thing. Since our goal is to use we have to do the ostial right, what we have to do in this situation is keep the guide in the ostium. You start your rotational atherectomy in the guide so that you actually burr the ostium.
You may burr a little bit of the tip of the guide, that's all right. Yeah, see, the burr will jump. Yeah, it's a 1.75 burr. It will jump, but that's okay. You come back again and try to ablate that ostial area once again. Yeah.
So, I mean, how much are you concerned that the guiding catheter isn't coaxial there?
Yeah, that's okay. That's the key. That clearly that this is where that extra support wire will help you. Like in this particular case, that your guide is as long as it's aligned, that's okay, because the burr will go. Now sometimes the burr may give a little trouble. That in that case you need to just bring the Dynaglide.
No,
one of
you have to go here.
Yeah.
One of the questions which has come through is, I do not have rotational atherectomy. Could this case be done with the cutting balloon?
Well, I would say ostial probably, but look at the distal calcium on the distal RCA. That will be very one. That is applies to any calcific lesion. No, guide. Yeah.
Another question which has come up.
But yes, I want to yeah, good, fine, let's try. Yeah, I would say that, yeah, that the answer to that is that it is possible but will be difficult. It's not impossible. You don't need to send this case for surgery if you think that you don't have rotational atherectomy, because this is a kind of case you can still, as you can see, that wire comes back, so that you advance the wire with the brake release. That the ideally, as I said, the rotational atherectomy, purpose of the rotational atherectomy is that to make a complex case simple. And this is the IVUS you do, it will be a circular 360-degree arc of calcium, and rotational atherectomy will make your the process simpler, although it has not been shown. Some studies have shown, yes, lower acute complication, but even the latest Rotax trial did not show any benefit of rotational atherectomy. So that issue still remains. But in my opinion, these kind of cases will decrease your overall stent use, and you will have a better expansion of the stent. But again, it's not proven by on any randomized. You need a little distal or no?
No, we're done. Yeah. So you saw how we got our burr. Once we did the ostium, to go to the distal RCA, what you have to do is you have to do the dynaglide, so that you can get a little bit of your burr to the proximal RCA, in which situation you go on the dynaglide and your assistant actually has to do the brake release. So then you manually advance the guide from your Y connector.
I know that was a very useful demonstration.
Yeah, as you see that the guide still remains little okay, that's all right. As long as the wire is enough and you keep moving the wire distally.
Well, also some very simple things like the use of an almost apicranial view to demonstrate the distal vessel very nicely. Samin, question has come for you. Is there any age cutoff you use for a drug-eluting stent?
Okay. I'm sorry, say?
Any age cutoff you use for using a drug-eluting stent?
Well, I mean, I would say the two different things. Actually, very interesting question just came up, and I'll tell you why. I had a patient for the TAVI workup yesterday, actually on Monday, the Friday. A 92-year-old, otherwise very healthy, normal activity. It hasn't gone to too many doctors, and of course found to have little shortness of breath and severe aortic stenosis. It's a good 92. Patient had a bypass surgery actually 15 years ago, and the grafts, the Lima was good, and the SIR graft is closed. Now she has a very complex distal left main circumflex graft lesion, which if you put a bare metal stent will have a 50% restenosis in the 6 months. Then question was, if you need to do TAVI, you have to delay the 6 month your TAVI procedure, but if you put a BMS, will become more difficult to manage. So in that particular case, despite knowing will be TAVI, and despite knowing that this patient 92-year-old, we put a drug-eluting stent. Therefore, coming back to the point, I think it's a more important is the overall patient's condition, irrespective of the age. Yes, we try to put a BMS in the older age. Idea is to the short-term antiplatelet therapy, but more and more we know that almost 6 months is required, because based on the Science V USA registry, that stent thrombosis after 6 months is almost negligible. Just like what we used to have with the bare metal stent after 2 weeks, very rare. So that with the DES, with the current generation DES of Zions and so, that you have a very low stent thrombosis after 6 months. So that my goal is basically is that yes, if patient has, we are doing it incidental, not for the patient's quality. Clearly we are not doing it here, improving the life in these elderly patients. From the quality, if the patient's issue is that otherwise patient is viable, it's better to put a DES and give us 6 months of antiplatelet therapy. You don't have to give it for 1 year. 81 milligram of aspirin and clopidogrel, or now of course you can use the ticagrelor, although we don't have much experience there yet. But those will be the choice of antiplatelet therapy in the elderly, and I will make a decision of the DES in that case.
I know in the last angiogram you took the ostium looks good.
Yep. Ostium now, tell what you're doing now, which wire?
I have a run-through wire which I'm wiring side by side into the AV continuation RPL. I think elderly patients also very important, as long as you know they don't have any bleeding problems, that they don't have had a prior CVA, no bleeding issues, and there is a family member who will take care of the patient and make sure that antiplatelet therapy is given regularly. There should be no age cutoff. Also, what happens is this elderly patient, calcific vessels, there is no point doing a very complex case and bare metal stent, and they come back with restenosis.
I know the serum creatinine was 38.
Yeah, where the creatinine clearance was 38.
38.
What, is,
No.
what is the creatinine today? 1.4. Last time it was 1.8.
Yeah.
So bivalirudin here, what are you using?
Yeah, bivalirudin is the agent in all our cases which routinely being used, and of course the bolus is adjusted based on the creatinine clearance. But that has been our preferred agent all, and of course patient.
What? 2520.
Yeah. So now it's a 2.520. The
For the distal segment.
Yeah.
the
distal.
quantum apex, high pressure.
Samin, another question for you. Why did you choose 6 weeks post LAD PCI, and what is the normal time you're using for a stage PCI?
Yeah, usually actually anywhere between 5 weeks plus, and although as you know that new guidelines, our recommendation point of view, that stage intervention, if you define at time 0, will still be a billable activity as of 2012, but your admission, unanticipated admission of the 30-day may not be billable anymore, so that usually we still giving it a 5
I think
weeks.
you need a regular balloon. It's not going distally.
Huh?
You need
It's
a
there.
non-compliant. No, it's not there. Give some dye.
Okay, yeah, that basically doing it for after.
See.
Yeah, go a little further. Yeah, no, we'll go. That after the 5 weeks is our usual, and in this particular case, we made it a little longer, and largely because of this very complex. Because we have been, few requests for osteal RCA, because a lot of people do get osteal RCA. You want to change it, or we can dilate
Go.
and
go,
see
go.
further.
It's not there. You need a little bit.
Yeah, yeah, no, the distal end few millimeter. Now also the point remains is that if you may not have gone completely, but if you, as long as the nose of the balloon is in the lesion, you can dilate, and many times your rest of the balloon will move in. It's a the 2.520 quantum apex non-compliant. Now whether you should use a compliant balloon and get a 2.520 apex, we'll see. Yeah, I think it's as you can see that he's making this jiggling motion.
Give me a.
Okay, let's dilate distal area.
This is exactly what Anu had mentioned would be the issues which will come up.
This is a stand. Okay.
A little further. Move.
Samin,
too
a
far,
very
it won't reach
interesting
it.
question for you.
Yeah, good. Yeah.
Somebody has asked what is happening to the PCI volume at Mount Sinai, and did you register a decrease for the year?
Yeah, well, actually, we definitely will have a decrease. The question is how much decrease. That's the issue. Overall in the country, as you probably know, and we know from the New York State being on the Department of Health, that we expect the highest. You want to osteum? That we expect the highest decline this year, even beyond what happened in 2006 after the Courage trial. Remember, Courage countrywide was about 16-17% decline. But it is expected because of appropriateness and lot of media issues and controversy of the stents. And I can tell you many of the cases, they are appropriate, but people are concerned to do those stents nowadays, so that it is expected that it will be about 25% decline this year. Now, having said that Sinai will have a decline, and part of that is this, most of the decline has been averted because of our outreach and networking activities. So that I think we'll have probably a few percentage, and hopefully by next month's webcast, I'll give you the exact number. But yes, decline is there now. On the contrary, just want to say, the cath volume is increased. And that speaks for the system process, that appropriateness, that yes, you are doing more cath, because patients are being, but clearly those patients who routinely getting the PCI in the past are not getting the PCI now for right and appropriate reasons. That they do not fall into that appropriateness criteria, which we follow very religiously. And of course that grid which I showed you here is in every room, so that everybody has been educated right from our fellows and nurse practitioners, of attendings, and you name it. And therefore, any question case is discharged that the patient is discharged and does not get a PCI and follow, and of course many of balloon rupture. There are many of these cases will now it will go. Yeah, as you saw it, the non-compliant balloon, compliant balloon of the 2.520 apex ruptured at 14 atmosphere because of this calcium, and now since we are still dilated a part of it, our old earlier the quantum apex should go now.
So, I mean, what is contributing more, more adherence to the appropriateness criteria or FFR?
No, I would say kind of both. In the sense that most important still becoming is the appropriateness. The FFR, just to show many of those cases which we used to do that IVUS, and I think the IVUS really we learned that criteria of the IVUS are changing while FFR remains 0.8 because basically which IVUS criteria you should be using for PCI remains under lot of scattership and changes.
Open the guideline.
Okay. So that the appropriateness is the more, but to me, and that actually really, and I would also say that most of the time when there is a question, use FFR and go away from the IVUS, because IVUS is really that we'll do more PCIs in the intermediate lesion based on the IVUS, as I showed a few months ago.
2512 high pressure balloon.
Anu, which balloon now?
No, the same. The compliant
Quantum
balloon is
apex.
quantum is not making it's not reaching that area.
But
So
do you
what
want-
we are going to do is take the guide liner, which is made by the vascular solution. If you see it here, it's just an extension of the guide.
The mother and daughter catheter.
That's it.
Whatever.
Yeah.
Yeah.
So, I mean, surgical volume, what is happening to cardiac surgery at Mount Sinai?
Yeah, cardiac surgery actually from the cabbage point of view, the volume is still continues to decline. So clearly the revascularization volume is overall decline, both Mount Sinai, both nationally, and I know for sure in the New York State. So it's not that the more PCI, despite our syntax which we are following very religiously, knowing that now the data at 4 years,
Get
that
the
even
balloon.
the intermediate risk patients, that they do syntax score of 23 to 32, they do benefit in terms of the surgical revascularization. Surgical volume has not increased. It's the overall revascularization volume has decreased. But what is happening with the surgery is that more patients with the aortic, because of the TAVI program and the mitral, knowing that the indication of the mitral valve surgery is shifting to the asymptomatic patients more and more, so that clearly they are having a more aortic as well as the mitral surgical volume. So that compensation overall, there is a growth of the surgical volume at Mount Sinai about 5% compared to year before. So clearly the more surgical procedures are being done at present, but not from the cabbage
So
point
if you
of view.
can see how to get the guide liner into the vessel. So if I had just gone over the wire, the guide liner would not have gone in. So what you do is I went with the balloon and then got the guide liner advanced over the balloon.
And that's the important point, that you don't need to push guide liner too much.
Yeah.
Once guide liner
Everything
comes
will,
there,
everything otherwise will fly out.
Yeah.
So now you have the balloon. On the balloon, you advance your guide liner.
and you can do the same thing on the stent. The time you are putting a stent, guide liner has enough lumen, it will go over as long as you are careful that you see not the stent migrating. Rare case could happen, but usually you will be able to advance guide liner on the stent, and then of course then you advance the stent further distally.
So, I mean, more questions for you. What is happening with peripheral interventions and structural heart disease?
Yeah, keep going. Peripheral
But
intervention
technical questions
continue to
are not-
increase very significantly. At present, we actually
Okay, now
expect-
you see with that we are able to get the 2.5 balloon into the
Excellent
distal area.
demonstration.
Yeah.
Yes.
It's a 2.5 quantum apex 12, right?
So,
Yes.
you're going to leave the guide liner till you
Yeah, I
dilate
will
or-
stay. Now it will stay there till we deliver the stent.
See why this is
See now you
balloon
see
rupture?
that. Yeah, the aim. In the beginning we decided probably we needed rotational atherectomy to that area.
Rupture.
Yeah, but now you
Open.
needed 3 balloons.
Yep, 18 atmosphere.
Anu, you think you would have been able to get the rotabur there?
Yes.
distally?
Yes.
Okay. So, this was the 2.5 balloon?
Yeah,
2.5
2.5 balloon. Now
quantum
12
apex.
quantum apex went up to 18. Now we have to make sure we just predilate it really well. Again, same lesion preparation, good predilatation before we think of getting a stent down there.
This guideliner is the key here of this case, no?
Yeah, it's
I
a
think
very,
it really
very
helps
important device, but
tremendously.
important is how to use it, because if you just think that you are going to extend it over the wire, it will fly out. You need to have a balloon first.
First, then
And
you
then,
come around.
yeah,
Yeah, that's
it
very
just goes very
important
nice extension.
teaching point. Yeah.
Go up here.
Samin, another very interesting question for you. This is somebody's mentioned. What do you think has been the most notable event in PCI in 2011?
The
Total
in terms,
occlusions.
in terms of the discovery, that actually, I would say that clearly, as you know, that the June symposium, I present. You can see a very nice. The present the most discovery. I definitely purposefully will keep that statement reserved. But yes, there have been a lot of the new things which have come in our field, and
Is
with
there-
my wait for the
You
top
have
10
28?
advances.
28 there, strength?
Yeah. No, we are using today the our same platinum chromium.
They have 28,
Promos element.
Promos element 28?
Yeah. 2.75.
No.
2.75.
2.5?
Yeah. No, 2.75. 2.75 and see, and then we will require 3 stents here.
So this
And
is key about how you're pulling this out. This
Yeah.
is really important. You show us that?
Yeah, it's coming out.
Yeah.
Yep.
But this is that guideliner.
The
you just keep
guideliner
it with you.
stays in place and
Yeah,
you're
you don't
working
move.
around
Yeah.
it. Right.
Sometimes you may see damp pressure, but we know that's because the guideliner is sitting in the vessel. Here, since you know your RCA is such a large vessel, you don't see any damped pressure.
And you are injecting with the guideliner being there, that's okay. Now it will give you some idea that in the proximal maybe there is dissection. No, it's a guideliner because
Yeah.
dye actually
Streaming.
coming out of the guideliner and going back.
And if you see how the guide, you know, do not touch the guide at this level, because the way it is working, the guide is at the ostium, but the guideliner is helping us that it is behaving like an extension of the guide to the mid
It's
RCA.
really important.
Samin, Dr. Costa has asked you a question. Would you consider a transradial PCI to reduce acute kidney injury because of less bleeding?
I can tell you the overall you take most of the data of the transradial PCI, you will have a slightly higher contrast use, although non-significant. But the bleeding, yes, bleeding point, but not necessarily for the kidney injury. And maybe I can ask Roxana to make a comment on it, but definitely transradial.
So there's never been a study that has shown that transradial actually reduces acute kidney injury.
Or, I
It
mean,
certainly
volume point of view
reduces
is like-
bleeding,
And,
and in
actually,
fact-
volume is slightly
And
higher.
in fact,
most of
there's
the
a little bit more.
Okay,
and that's an important thing.
Samir, if you see here,
It's difficult to push it.
if,
Huh?
yeah, but still I think we have reached
You
where
really
we
have
wanted
done
to.
it. You're almost there.
Show the guideliner now. Now she can advance the, Anu is going to advance the guideliner, your stent is there, give you a little extra support. See
You
that?
can see the guideliner is
That's
extending
such
all
an
the way down.
important-
Yeah,
You think you are far enough for another millimeter or two?
I think
Or we'll
maybe
take
She
another
another
wants to
millimeter.
go in a little
Now it
more,
will
I
be
think.
Yeah, I think now we got it in.
Definitely.
Okay.
You take a
But
picture.
that is how you do it. Means you get your stent down, and then later on get your guideliner over the stent or the balloon,
Take a picture.
so that you'll be able to get your device where you want to.
This is a 275 or
Yes.
what? Okay.
275,
You don't wanna go
28
too high.
platinum chromium. Now remember this one, you can go compared to a Zions, we never used to go beyond 12 atmosphere. Actually now I go routinely 16 atmosphere with this, so that you don't need to post dilate routinely, because it's a very nice radial strength. Ready?
Well, the
We covered
side-
it or no? Let's see 1 second. I think this is a very crucial point. Yeah, we have covered it. Yeah, okay. Let's see where we are now. Go to the last picture. We have to go beyond that very large AV nodal branch. Somehow become very big. The
And
patient.
This is exactly the same projection you're using?
Yeah.
Yes, yes.
Same.
I think you're beyond it.
No. Yeah. No, let's see where
You want
we
to
are.
go wait?
No. Yeah, you need
Yeah.
a 2 millimeter more.
A little further.
Yep.
So maybe a little more deep throating with the guideliner.
Guideline. Yeah.
First thing now, right, you need is your wire has to
Wire.
go.
And the
Yeah.
guideliner?
Yeah.
As promising as you have been describing the Zions Prime, the Endeavour Resolute, and the Promus Element, these stents have been available in many parts of the world for a long period of time.
That's true.
Dear, take
That
a
is
deep
true.
breath.
Therefore, America is a little slow, but let everybody else experiment things and get to the more advanced designs and so. Yeah, but clearly, yes, that has been we not only that to me.
Yeah.
The biggest issue was the size, length. I mean.
I think we went.
You got it.
Yeah,
You got
now
it.
we
You
did
got
it.
it.
Now, particularly 38 millimeter. I mean, having
So the final thing that helped is the guide liner, and
Deep
you
breath.
see it at I'm moving forward. Patient takes a deep breath, and deep breath is also a very important feature in interventional cardiology.
yeah, deep
Good.
breath is a cheap guide liner. I would say the deep breath is a cheap guide liner.
And fellows know it. They try do, and we say, how come attending comes in and gets it in less than 10 seconds? Yeah, nice.
You select the stent for the middle
Down.
quickly now. Because
Yeah,
we got few
3.5.
minutes. Yeah, 4.0 even. This still could be
For the
4.0.
distal?
Yeah. Okay, 3.5, 28. Okay,
Okay.
good. Now 16 atmosphere.
And but ostium we didn't prep.
Yeah, ostium we need. The question is ostium. Do we need a
Column.
4.0 flex tome followed by a 4.0 stent? And actually, you can expand the Promus element to almost 5.5 millimeter, beyond 1 millimeter, can go up to 1.5.
Okay.
Yeah, because the ostium definitely is in the 4, 5 to 5 range, no?
Yep.
Yes.
Exactly 5.
Same
Five
now
range.
you
You're
see
taking-
you're not moving the guide liner. It sits there because we have another job to complete. And then when we are doing the ostium, we take the guide liner out.
So would TAVI be the biggest expectation coming in for 2012 at Mount Sinai?
Well, I mean, for Sinai, absolutely all the same. That we did a first case in December.
How many cases have you done now?
Now we actually 32. There was one case waiting now. That becomes 33. And we
So
got
you're-
few
you're-
approved.
You're doing virtually a case a day?
Well, no. Well, ultimately, I would say I don't know whether you will have a 250 volume or in the future. But yes, many of the centers which will go away, particularly when you go to the lower risk group. Yeah, definitely that will start happening. But that's the second part of the core valve called CERT-AVI, the lower surgical risk with between 5 to 10% of your STS mortality. It's still not a very low, the medium. Take a picture.
I don't know where we have some guy. Okay, good.
Good.
Go up.
Yeah.
Perfect.
Get a 4 flex tome.
4.0 to go post time.
Yep. Okay, again 16 atmosphere, you can see that at 16 you don't need to go higher, but 16 is good.
I think you're good. You might just need inside the stent
Yeah.
a little.
So, Samin, how much do you think
No.
is this going to change your strategy of going back and
Or
dilating
open
with
the
the
ostium?
Well,
non-compliant balloons?
I mean with the Zions Prime and Zions, we were using almost at 70% of the time post dilatation, and now with the at present Promus, we just started Promus element a few weeks ago. That the use of the post dilatation in my practice now has gone down to 1/3. So definitely has decreased. And just it's not that as we used to be with the the days of the cipher where that number was basically 10-15%.
Yeah,
Maybe it
Dito
will,
needs a little-
but we just need to see.
Well, the
let's go to
conformability looks very nice
Yeah.
in the stented segment. You wonder, it has to be a combination of the platinum with the chromium which has probably done the trick, because after all, platinum is nothing new to interventional cardiology. We discarded those stents 15 years ago.
Yeah, except that I think the portion, now you want to take the guideliner out?
Okay.
Okay.
I'll get
Yeah, that
get this in and then take the guide liner out.
So
the portion, the platinum percentage now in the platinum chromium being about 30+% is the difference only, and that also gives the radio opacity.
Anu, take a look in this particular view. Are you concerned with the ostium of the very distal
That,
branch?
that is there, but as long as it remains fine, it's okay. But
It's
you're
not
right.
going.
There is an issue in that the AV nodal branch, which we are calling. So
It's
that
a pretty large
Yeah,
branch,
large branch, yeah.
providing collaterals to
Yep.
the.
It's not going. Okay, good.
okay. Then therefore 4.0 flagstone will not go through the guide liner. Okay. That has been said. Actually 4.0 stent may not go through the 6 French guide liner.
Not 6 French. This is the
7
7
already.
French, even 7 French.
Oh, even with the 7 French. Okay.
3-5 sometimes gives us trouble. Yeah.
Yeah.
That's
The,
right.
clearly, we take the guide liner out
So-
because you probably don't need now.
Would you consider a 3-5 and then post dilate to a 4?
No, but
we know the name.
You
take
can
the
do it,
guide
you
liner.
don't
We
need the guide liner
Yeah, we
anymore.
don't
May
need
not
guide
make
liner now.
the turn.
Yeah, we don't need the guide liner now. Now we just have to quickly do the ostium and finish our case. But clearly it needs the ostium still need a little more work. So coming back to the point that yes, that what you do in a large, you don't need to go to a very large burr. You just go to a medium and small size, medium sized burr, and you do little eccentric cutting, and then you do a flextome or angiosculpt in some cases, open up the ostium, and then you dilate. And the dilate basically, where will be the ostium? You put another wire into the aorta so that you know exactly where the ostium of the RCA is for accurate positioning. Although you can use the Szabo technique, which we have shown actually in our symposium, but not now. But although the Szabo gets a little more complicated sometimes, that unless you are really crimped it and you need to pull it back for some region, that it's a little, stent may strip. So that overall, I think if you just put a wire into the sinus and put in the ostium, your stent deployment will be good enough. Now this is a 4-0, a 6 flextome.
Nice.
We're a little further.
Yeah, pull back. Okay. Yeah.
Okay.
Go up.
Good.
Down.
Moved. Yeah, this will happen. Even those in this short, angulated lesion, because of the angle, the things will move. That as long as you are careful, you pull back again.
They have a 4-5
this time-
stent? 4-5?
No, 4-0. 4-0.
No, they have.
No, we
don't
don't have
have
4-5.
4-0.
No, 4-0. No, 4-0.
Go.
4-0, 18 or 16, and then we
This is a
post
balloon?
dilate with a 5-0.
Okay.
Cutter.
Good. See, this is a nice one. At
So
8
now what you
atmosphere.
do is when you know you dilated the ostium, then you pull your guide out a little bit. Yeah.
Yeah.
Down. 16.
Yeah.
Then you want to post dilate.
And then we'll dilate with a 5-0.
Okay. Now
Yeah.
come back here again.
Good.
Yeah.
Okay.
Now other question thing also you need to be worried when you're doing multiple dilation of the with the cutting balloon at the calcific osteal RCA after 3 inflations, likelihood that it could rupture.
The stent is long, right?
Yeah.
Longer.
16. Yeah.
16.
Yeah, 16, okay. Because remember the ostium is a little far away from exactly where it is coming from. And this is a 4-0, 16, and we'll dilate with a 5-0. Our non-compliant quantum apex 8 will be good enough. 5-0, 8.
No, 12,
Or 15. 8 or 15.
15.
Okay, 15. Go.
Don't stick out too much. Okay.
We'll put
We
the
found
wire
the
side by
stent.
side.
No,
Yeah.
no, we're not doing those things. Just do it like this. It looks good. Don't put all those wire and this and that.
Okay. Now this is the key point now here.
No, you want to go straight LA.
Yeah, I was wondering if you need to change to a more
Yeah.
LAO.
Different view. Yes.
Yeah, we are going to LAO or even a
Absolutely.
caudal.
Yeah, this was.
See that?
Yeah, this is a perfect view for it.
Yeah.
Yeah,
Take a
no.
picture.
Yep.
You
Okay.
want to go caudal?
Yeah, picture. And
A little more caudal. One
more
second
caudal,
before we take a
more
picture.
caudal.
Bring this down. Yeah. Good.
Good.
That's good.
Okay.
Picture, yeah?
Mm.
I'll
Yeah,
pack.
nice.
You got to
Beautiful.
pull back a little, no?
Yeah. No, we'll be fine.
Good.
Yeah. Ready?
Yeah, go.
Okay. Now clearly once you start, then you start taking your guide out.
Not yet, not yet.
Yep. Otherwise stent will deploy in the guide and guide will take the stent out by itself.
Good. Now.
So now you go
saw
same
that?
16 atmosphere.
Pull back
Very
a
nice
little.
demonstration.
Yes.
But don't go high pressure because you feel the stick
Means
inside.
when you are at 10, between 10 to
6
12
and 10.
atmosphere, you just get your guide out. But it's very important, either the stent will strip out or the
Okay,
entire
okay.
mechanism will come out. So you have to be very careful when you do that.
Let's pull back a little bit
Yeah.
and do.
So now you put the
Ready?
guide back in.
Yeah,
Okay.
yeah.
Ready?
But here,
So
with this new stents, you have to be very careful.
Samin, important question for you. What is safe?
It's really
and
go high
maximal-
pressure.
What is the safe and maximal pressure of flexitome in the osteal RCA case?
I would say the safe 8, maximum 12. If you need to go to high pressure, then you use angiosculpt, which you can go to 16 to 18 atmosphere.
I have also
Go up
found
again.
today's presentation more noteworthy because of the multitude of questions we've been getting, all very relevant, making it truly
Now this is
interactive,
other
and I
thing
want
that
to-
you could do
Trumpeting.
is when is a flaring at the ostium.
Go to other view now.
Yeah, but she's.
You want to go to high pressure?
Yeah, it's
No, I'm
not
using
showing
a high
the flaring.
pressure. But we are using a high pressure. Yeah. This is a very big vessel. We go with the high pressure first. Now here, clearly advancing the guide is very tricky because otherwise you may distort the ostium, the stent which is a few millimeter out of the ostium anyway. So that you advance the guide
you're
on
good.
the balloon. Yeah,
Beautiful.
Good. Let's take it out.
This is
Then
ostium
we
is
do high
destroyed.
pressure. Yeah. Don't take a picture of take a high
No,
pressure
high
first.
pressure.
Yeah. Now, you know what I'm trying to see that from our educational activities point of view, that that maybe in the end of presentation we'll have a few questions, like 2 of them or 1 question at least. 1 question, and person who answers that online gets some special prize. So we have to work with the hard.org. Starting next year, I always had to do something. So in the end, from the presentation will be a 1 question asked in the end, and if the person first one to answer correctly will get some the special prize. Whether we can do it or not, that we need to see. We want to be within the compliance.
Go.
Okay.
This is a 5.0 Anu.
Yeah,
5.0.
down. Yeah.
5.0 at 16 atmosphere, and most important is we need to do the ostium. And clearly that you need to
Show
go.
us again how you pull that out.
Yeah.
That's really a very good maneuver.
Now I'm coming out with the guide because otherwise the balloon is not going to come out. See that?
Right.
Good. Now you know
Now you
it is
put
in
it
the guide.
there.
Yeah. As he
Go
goes
up.
up. Good.
Now you pull it out. So nice.
See that?
Yeah.
Good. Now.
Very nice.
You need to put a few more millimeter out.
She's going to, yeah. And then you trumpet.
Mm.
The flaring or whatever you call it.
Why are you doing this 100 times? Okay.
That's
good.
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 Nice.
Ready?
Yes.
Okay. Now clearly
is
the
flaring.
the balloon may come back, but that's okay.
That's
That
the
if
So
it is, then
you
you
see, you go with your guide, you
push it
butt
down
at the
again.
balloon, and then you go down, you pull up.
Samin, at
Send it
this
this.
Yes.
moment, in this particular last inflation, you think the proximal portion is slightly outside the struts?
Yeah. Oh yeah. Absolutely. And we want that.
So you're
You see that compliance with the balloon telling you, because the stent, the area is not, once it is out, it is fully expanded, that area. So clearly that you can see based on that a few millimeter has to be out. That's the only way you can flare the ostium. We go back to our same view, which we have done all the work. We take a picture, and I think we are reaching to the time, and then we'll see. Ready?
Give some nitro or no?
Take a picture. Yeah, will do.
Beautiful.
Good. If everything is okay, I think we are reaching to our time. Few minutes extra, about 8 minutes. But part of that
okay.
is because of the complex case, and this is what we really wanted to show and demonstrate. And come back to our last 2, our take-home messages.
Samin, before that, how much is the total contrast volume you used?
Total contrast volume
120.
120. 120. But clearly, with the 7 French, we'll use little extra anyway. So that's the issue. So therefore, I think if we sum it up, the 2 again, the important points, that the newer 3rd generation DES seems to perform better in terms of delivery, lower malapposition, better radial strength, and similar lower stent thrombosis rate and MI as of 2nd generation DES. So the very, very important point, the 3rd generation stent, I think, will make away or neutralize some of the drawback of the 2nd generation being a thin strut. Second, and very important, that the preferred choice of a contrast media for prevention of kidney injury or CIN has not yet been settled, as obvious by 2011 ACC guidelines. So clearly, that anybody wants to make a claim, We may feel differently, but that is what the official statement is. No contrast is superior. And that's a good news overall, I would say, for the media, so that clearly from cost point of view becomes better for everyone. Then what I can say, and I can, based on the scientific evidence, that the iopamidol appears to have the edge over other low as well as isoosmolar contrast agent in terms of reducing AKI, but more importantly, lower long-term base. There is no data in the literature, what you have the 1 year follow-up of the care, showing that what happens to these patients at 1 year, and clearly seems to be that it is not just that those who develop events and so, but the key is that it's the contrast, because always question was, is it only the contrast in nephropathy, or it's the contrast agent which have a bad adverse outcome. And I can say that there was 70% of patients to the 450, means 280 patients which were followed 1 year in the care trial, is the largest of the long-term follow-up to answer that question. That yes, it is clearly contrast mediated. It is an acute kidney injury caused by contrast. At the same time, iopamidol seems to have a lower major adverse event at follow-up. With that note, Anu, you make your last statement and we call for the day.
Yes. I think here demonstration of technical point of view is how you handle the osteal RCA. If you see, calcific osteal RCA, whether you are using a cutting balloon or you are using rotational atherectomy, I think we've shown both of them. And for the distal vessel intervention, be it calcific LAD, RCA or circumflex, even when sometimes the takeoff of the circumflex is more than 90 degree, this use of guideliner has really helped us to deliver the devices to the distal area, as demonstrated here, that we were able to get without double wire. In the past we have shown that the other way to do that is use double wire, sometimes maybe even 3 wires, but with the help of the guideliner we are able to deliver the distal stent in this kind of a tough case.
Anu, we see your entire team. You want to show us who else is behind you?
I mean, these kind of cases we do every day, and who normally help us, our interventional fellow. I have a John Odia who actually is visiting us from Ireland. He finished his MD in Ireland. They do 3 years of research, and he wanted to come to Sinai. He specially selected Sinai to get overall experience in every aspect, peripheral, interventional, do complex cases, so that when he goes back he is fully trained. And I think after this year he wants to do 1 more year of even the valvular diseases, and then he'll be going back to Ireland. But the important thing for us is to run this busy lab. Other than the help of the nurses, technicians, we call our interventional fellows as our backbone, means they have everything ready for us. Otherwise this complex case in a normal day, we do it just with the interventional fellows' help.
And here we have Vicky. I'm sure most of our webcasts have been done with and of course Derek and Pablo being the Cardiff CVT, and the rest of our camera crew and here. And clearly that I will just make a last statement, or I'll ask to finish today's with asking Roxana that any future about a non-iodinated contrast we'll be using ever in our PCI, hopefully that may eliminate, or is there any theory behind or about those agents coming down the pike?
So I think the quest now is on finding a contrast media that's actually safe for the kidneys and maybe even bypasses the kidneys for clearance. This is really the quest for the future. I think that it's very difficult for us to perform our studies without contrast media, but the question is, how can we find the safest contrast media to deliver? And the most important thing here, I think the message, given where we are today, as you already discussed, is in really understanding our patients' risk factors, minimizing the load of contrast, and preparing the patient for this kind of an insult. But the future is going to be looking for contrast media that actually avoid kidney for clearance. And I'll tell you, it's interesting that you ask that because there are a couple of actually small biotech companies that are working on this. So it'll be very interesting to take a look at that.
And knowing that in the guidelines, besides hydration, the very much emphasis on decreasing the contrast use during your PCI. And therefore, maybe Anu can sum it up today's presentation, because this is such a hot topic for everybody, that what can you do by decreasing the minimize the contrast material, and actually during the PCI. Now, actually, I have one more person to introduce, my nurse practitioner, Antoinette, who has been all the time helping, and of course,
Take your mask off,
yeah,
please.
mask. The mask is off is allowed. And with that note, Anu, you want to give some more tips?
Yeah. I think for the interventionist of the various, cause for kidney CIN or acute kidney injury, which is shown by Dr. Sharma, I think what we believe is patient preparation, and lot of it is not in our hands. You can say 30 to 40% of the patients already have heart failure, peripheral vascular disease, and along with that they come with the creatinine, which we are talking about 1.9 or 1.9 to 2.1. There is no way you can hydrate as when their EF is usually in the 30 range. So give minimal hydration. If your EF is normal, I always tell the nurses, they know that hydrate them before, which could be 3 hours. Just give good hydration, and when they are preparing the patient, give a bolus anywhere between 300 to 400 cc bolus. And the most important for us, which our fellows know, that the volume of the dye has to be very low. Even in acute MI setting or in this kind of renal insufficiency patient, never go beyond 3 digits. You have to stop between 70 to 80 cc dye. That is the key thing, I think, for us interventionalists, that we can do to avoid this important complication.
And particularly in this particular case, we knew this one will require 100 plus. It had to go to 3 digits. This kind of complex case, and that is one of the reason also we gave enough time for kidney to recover. Actually, creatinine today was lower than when she had it to a PCI back in mid-October. And having said that, maybe finish it. The last one, that what about, do you believe in sodium bicarbonate? Anu?
I personally do not believe in sodium bicarbonate. I think our cardiac patients, unless they have a normal blood pressure and normal EF, we cannot use them in cardiac patient, because most of them have a risk factor of hypertension. The sodium load we give, they become hypertensive waiting outside. And EF, if we are talking EF of anywhere 45 and less, as soon as you give couple of cc's of soda bicarb, I see the nurse or the nurse practitioner calling me, the patient is coughing. And we've had this experience a lot, and I personally don't believe just hydration and decrease your dye load would be the best way to prevent this complication.
And starting the next year, always we try to work few things. One which we are adding to the live webcast is adding the endovascular. As you saw the interest by our viewers, and so seeing an endovascular case. So Prakash Krishnan with Jose Wiley and George Dangas being a moderator. We'll start having an endovascular case once a month, one particular Wednesday. I think it will be a second or fourth Wednesday of the month will be starting as of next month. And idea is towards the end of next year, that mid next year and later, that we'll start one dedicated day per month also for a structural heart disease, and performing percutaneous the percutaneous aortic valve and other structural heart disease webcast, so that we continue to grow. And I really thank all our heart.org and Medscape, as well as our viewers, who have been a great strength and keep stimulating me, coming up with some new ideas and making slides until the last minute. But I took the pledge, and I was here right just 1 minute late. Starting next year, even that won't happen, that we start in time, but provide the latest data unbiased on many of these controversial topics, and push the field further. And this is clearly shown by the enthusiasm that anywhere between 3,000 to 5,000 web hits per month, cumulative web hits, knowing that acutely probably about live 800 to 1,000, but more overall 3,000 to 5,000 plus web hits has been a very satisfying experience for myself, for Annu, and I would say rest of our cath lab team.
Samin, congratulations to you. Happy holidays to your team as well as to our viewers. It has been a fantastic year, great progress, excellent cases, demonstrating all the fine tips and tricks in an unbiased atmosphere. My congratulations to you. Happy holidays again to everybody. We'll see you back next time, January 17th.
All